Okay. Well, hello. That wasn't very good. Hello there. I hope you're sitting back in your dorm room or apartment nice and comfortable, so we can be nice and comfortable as we go through this digestive system. So I'm going to talk through the slides just as I would during a normal lecture, highlighting the major structures that I want you to really focus on. And if you have any questions about this, please keep note of them, and we'll be able to answer them in class after Thanksgiving. It'll be all right. So here we go. So we're going to talk about digestive system. This is a systemic approach to this type of anatomy where we're looking at this whole system wherever it is. And of course, this digestive system goes from your mouth to the anus. And you've all covered this system a lot over your years. You know where your tummy is and your innards or entrails, you may have heard, as far as your small and large intestines. Some things you have heard, of course, before, but hopefully we can cover some additional structures for you to learn for this semester. That's good. All right, let's get underway. You can see a nice picture here showing this digestive system, including this long tube that goes all the way from the mouth to the anus. And there's some extra structures, organs that are going to help us with our digestion of our foods and fluids as well, like the liver. There'll be a pancreas sitting behind the stomach, and even our teeth and our muscles within our cheeks, and all help us to get that food all broken up and get ready for absorption. We'll see. So let's move on. Okay. So on the left here, I see that there's the tube and all the parts of the tube. The tube is the digestive tract. I learned it as the alimentary canal, but digestive tract all the way from the oral cavity or the mouth all the way through the large intestine to the anus. So you're familiar with these parts. Oral cavity, the pharynx is your throat. The esophagus is the muscular tube here to the stomach. You knew that. Small intestine, large intestine. And that'll be our tube or our digestive tract all the way through. But to add on to that, then we need our teeth and tongues, salivary glands to give moisture and even start the enzymes to start some chemical digestion in the mouth, but mostly to moisten the food so it goes down nicely. Our liver, biggest organ of the body here, our liver is here to do a lot of help with the digestive tract with that green bile. So green bile, we'll talk about that later. Gallbladder holds that green bile. If you aren't using it right now, so right then you can save it. And a pancreas, as I mentioned before, to help us with digestion. You've heard of pancreas before as far as insulin and glucagon hormones for other purposes, but they also, the liver and the gallbladder has digestive roles as well. Okay, good. 8 functions of the digestive tract. Wow, it seems like a lot. Huh? So in order to get our foods and our fluids into our bloodstream, really where we can use it throughout the body, we have to do a lot of things first. Okay, it won't go across cells or through cells without some. First, we've got to put it in, and then we got to break it apart, and we got to do some chemical digestion, meaning chemicals, the enzymes take down, the proteins will take down some other food substances in smaller molecules. Stomach, we'll see later, produces hydrochloric acid in your stomach, which actually helps this chemical digestion. Some secretions like the liver and the pancreas I mentioned, but there are other secretions from epithelial cells all along our digestive tract as well. And absorption, highlight that one. That's the most important one, because absorption is where the fluids and the food molecules at that stage, that level, go into the bloodstream and in the lymphatics too. But that gets back to the veins in the bloodstream, of course. Lymphatics will drain all their lymph fluid into the subclavian veins into the heart. So that's good. But that absorption, if we don't absorb it, it's just going to go right out the alimentary canal and be gone. And so we want to make sure that we can absorb the right things. And so this is a critical step, is the absorption right here. All this stuff gets ready for the absorption. Then if we don't absorb it, then of course we just need a compactor, the large intestine, to compact, which really is to take out fluid. So we can still grab fluid out of the feces in that stage in order to keep that water content so we can use it. That's good. And then excretion, when it's socially acceptable, is a good time to do that. Good. All right, moving on. So which one's the most important for the test? Absorption. That's good. Next, histology of the tissues, or really the layers at this stage of the digestive tract. So from the inside, we'll have a mucus layer on the inside. We'll see those are epithelial cells that are going to protect, but also to absorb all these fluids and food. Mucosa is the innermost layer. We're going to go over each of these individually, but here's overview. Mucosa is innermost, then submucosas, blood vessels and lymph vessels, nerves. The muscle layer, of course, you can see the muscle layer here will be the muscularis externa. These are the muscles that actually move the food substances through the alimentary canal. And the outside layer is the serosa. You see the connective tissue on the outside, so serosa is connective tissue, or externa is also called that, or adventitia. I learned it as adventitia as well. Okay, so let's look at each of those layers. Oh, actually, before we get there, notice that there's these rings inside here. Those are extensions of the mucosa, the deepest, the innermost layer. Mucosa has these big extensions in, and you can see how much surface area that adds to the mucosa layer by having these circles of mucosa. And we'll see that they're really called circularis plica. Circularis plica. These are these large extensions of the mucosa into the space where the food will be. Good. So that's good. So this is a plica here, the whole thing. It doesn't look like a whole ring, though, like the previous slide shows a nice ring of extension into the open space. And you can see again that adds surface area tremendously. And on each one of the plicas, we're going to have lots of little bumps. Every one of the little bumps is a villi. Each little bump's a villi. And on each villi, there's lots of epithelial cells that are covering it. And so with all those villi on all those plicas, we have a huge surface area throughout the digestive tract. And that's good because that's where all the absorption takes place, is actually through the epithelial cells all the way into the bloodstream. So when you absorb, it goes through an epithelial cell. So I was amazed at how many millions of those then we'll have in our digestive tract, and that all the food substances and fluids have to go through an epithelial cell, not between them, but actually through them in order to get absorbed. So that's the mucosal epithelium. Lamina propria simply means a little bit of connective tissue. Basement membrane, you might see in a different book, but lamina propria, just a basement membrane or connective tissue, just to hold these epithelia in place. That's all. There's a wee little muscle layer way up here. A little bit of muscle goes up the plica and down again, and that's just enough to wiggle the plica. It's not moving any foods along the alimentary canal, but it's just wiggling. And if it wiggles, then the food substance is moving around, and that way it'll cross over more epithelial cells to do the absorption. So this layer of muscle is just to wiggle, as I learned it a long time ago, wiggle the food substances just to allow it to churn a little bit and pass over more epithelium. I think we did it. Next. So in that submucosa then, so instead of the mucosa from here up, mucosa, then now we're in this layer. And so as I was looking over this earlier, I was realizing, well, there's no absorption in the submucosa. All absorption takes place in the mucosa. Sounds like a good test question to me. Remember, mucosa is where all the absorption takes place. So now we're in the submucosa. We've already absorbed food substances, molecules, fluids, and now they're in the blood vessels. And you see the little blood vessels reach up into the plicas to do the absorption. And there's not shown very well here, but there's lymphatic up in here too. And a lacteal. We'll see another picture of that, but that'll be up there too. So we do absorption in the capillaries as well as in the lymphatics a little bit. Good. Areolar tissue surround the muscularis mucosa. That's this. Areolar tissue means loose connective tissue, so that'll be within here. This is all connective tissue in there, at that layer. Good. blood vessels, lymphatics, exocrine gland. Exocrine means outside the body. So, but there are glands here, mucus. You need some mucus cells. These are all epithelia, and they're going to release mucus onto the surface, which then coats and protects those epithelium from that hydrochloric acid we'll talk about in the stomach. So those are some of the exocrine glands. Now, exocrine usually means outside the body, but this isn't going outside the body. This is going inside the alimentary canal. And there's a funny definition for that, is because when you put something in your alimentary canal, you're not able to use it yet. So it's still considered outside the body. I mean, you're not using it. It's inside your body, of course, but you're not able to use it yet. So anything in the alimentary canal or this digestive tract is still considered outside. So that's why these glands are called exocrine glands. They're putting things in the alimentary canal, and to help with the digestion before it can be absorbed. But we're not able to use it yet in the body, so that's why these are called exocrine glands. That's why the liver is going to have exocrine function, because it puts bile into the digestive tract. And the pancreas does too. And these little glands here do as well. Submucosal plexus. The word plexus, I've said before, means a collection of nerves. So do we see any yellow nerves over here? So we see a whole layer of little nerves. And those nerves have to be there in order to innervate the muscle layers there as well as in here. But also nerves are going to be sensory. So you know when you have lots of tension within your stomach after Thanksgiving dinner next week, and also maybe extra gas so you feel that pressure in there with some sensory neurons. So that would be also within this plexus. Good. Sometimes I think I'm talking a little fast, so just stop it and push it back a little bit and listen to it again. That'll be the best thing to do. All right, next layer will be the muscle layer, the muscularis externa, or the muscle layer. And you can see clearly that there's two sets of muscles, two layers of muscles in the alimentary canal. So the innermost layer is the circumferentially oriented, so obviously going around. So they're going to go around the tube, all the way down the tube, going around. Versus the longitudinal oriented layer in the outside, it goes the length. The fibers are running the length of the alimentary canal, or not the whole length, but in a lengthwise orientation. So you can see that they both will squeeze and will both work to push food substances along the alimentary canal. But you can see the innermost layer, when they squeeze down, they do constrict, that they can limit how much flow is happening. And sometimes we'll see specialized circular muscle called a sphincter. And the sphincter can close way down and actually be a valve and stop food substances from moving on. We need that at the stomach, at the both ends of the stomach, to hold things in until it's time to release it into the small intestine. Okay, muscles. So when we talk about the muscles, then we do talk about moving the food substance throughout. There are some specialized pacemaker cells, special muscle cells, that will actually trigger this contraction to take place and move food substances forward and backwards in the alimentary canal to do lots of movement and mixing. So the first word you've heard of, peristalsis, probably. The peristalsis, this is a wave-like contraction of both the circular and longitudinal layers as it then pushes. You can see if it's going to squeeze down, it's going to push. Maybe this way, it's going to want to push it forward, you're going to push it forward. But sometimes the contraction wave comes back too and pushes it back and forth a little bit. The net movement, of course, will be forward, but it does go forward and backward to get more mixing, more churning, more pushing all this food substances by all the epitheliums. You go forward, you go backward and forward and backward, so that we can do all the absorption possible. Good. So peristalsis is a net movement forward. Good. Segmentation, you can see, what if it all squeezes at once? And then just kind of wiggles. And then we see lots of mixing. So this is whenever we have segmentation, because you can see the segments whenever this is formed. And it's going to be lots of churning, a lot of mixing in order to, again, get some mixing going on in the food substances, as well as absorption in the mucosa layer of the alimentary canal. Most of that absorption is going to take place in the small intestine. So if you had to name one part of the small intestine to do the most absorption, by far, most of it is in the small intestine. We start absorbing in the stomach, and we can absorb in the large intestine, but most of it is in the small intestine. Good. Oh, I just like this X-ray. This is an X-ray. Isn't that a cool looking X-ray? But it's a specialized, stylized X-ray image, and it shows the stomach and the small intestines down here. So it's pretty cool for X-ray. You usually don't see soft tissues in an X-ray, so I thought that was really good. But it talks about, why does your stomach growl? And certainly we need that peristalsis activity to move the food substances throughout. But after, and it said in here, I think there's a website that I got this from, that about 2 hours after your stomach empties, then the muscles will contract again and try to get everything out of it. So just to check it to make sure that all the food is out and moving. So it is contracting and squeezing fluids and moving around, and you do hear a little bit of those noises too through the stomach. But most of our noises, though, when you hear something gurgling and all, most of that's in the small intestine, not as much in the stomach. Cool. All right, how is this all packaged and organized in here? This picture is a mid-sagittal cut, mid-sagittal, looking just at one side then. And so, of course, you know that we'll have connective tissue that's going to hold things together. It doesn't hold everything directly, absolutely in place. Things can move around a little bit. You've seen that in lab of moving the intestines and things around some. But they do connect together, and we use the peritoneum to do that. So connective tissue that holds things in place is called the peritoneum. This is similar to the pleura up in the thoracic cavity. We have the parietal peritoneum is on the outside, so it lines the inner surface of the abdominal wall. So that's on the outside part, around the back side, all the way over the uterus and bladder, and just inside the abdominal muscles would be the outside parietal peritoneum. The visceral peritoneum lines right on the viscera. So if you're actually touching the small intestine or the stomach, then you will be touching the visceral peritoneum, connective tissue that is on the surface of the organ or the viscera. Good. All right, so then they interconnect. So there's a connection. So up here we see that, and all of a sudden there's parietal peritoneum, then there it goes on the organ. So then that'll be visceral peritoneum. So there is some connection there between the two peritoneums. Where there's a double layer of peritoneum, 2 layers coming together, double layer, it's called a mesentery. So the mesenteries are fused double layers of peritoneum membrane. Good. And in a real thin body in lab, we can actually see all the blood vessels in the mesentery. But usually there's some fat in there. So usually they look yellow fatty membranes. So that's usually what we do see, though. Okay. There's different types of mesenteries. The lesser mesentery, greater mesentery or greater omentum is probably obviously the biggest and the most strangest looking one. Let me see. I threw an extra slide in here. Look what's attached to the stomach, the bottom of the stomach. What we're going to call the great curvature. There's a big curve of the stomach, great curvature. But we see this fatty sheet attached to it, and that goes down across all of the small intestine. So all the way down to the pubis. So that is the greater omentum. It really is great. Really big fatty apron. So is what it stands for. It's good. It's a good insulator. There's fat there. It's going to insulate, keep all the intestines of the core temperature warm, and for protection as well. So this is just inside the abdominal cavity, just inside the parietal peritoneum will be this greater omentum. Let me go back a slide or two to see if I've missed anything. I think that's most of them. There is a lesser omentum here. You can see it goes between the stomach and the liver. So that's just a little membrane. Here's the stomach. So just a little bit is lesser omentum. Pretty thin. There's not much fat up there. So in lab, you have to break through that in order to see vessels going into the liver up above. Here's the greater omentum from the stomach down, loops down and back up again. It looks like a single tube here, but remember it has width from side to side. So it really is a apron of fat that is over all of the intestines. So it's mesentery. Greater omentum is mesentery, and it contains fat, storage for energy someday, and it has lots of blood vessels in it too. I think that's good for now. There's some others. I'm not going to test on these. There are some other sheets of connective tissue holding things relatively in place. The mesocolon to the colons or large intestines, known as your colon, and there's some others, but they're difficult to find. They're actually a thin membrane that you can see through, so a little difficult to identify. And we usually break them apart to see other structures. Okay. So now we talk about, we have this abdominal cavity here, and everything in it is called to be inside the peritoneum. So that would be intraperitoneal. Intraperitoneal is inside the abdominal cavity. So those are your stomach and the liver. The jejunum is part of the small intestine we'll get to, and ileum too. And it's part of the colons, the large intestine. But there's some of the parts that go behind the parietal peritoneum, that membrane that lines the cavity. So it can sneak behind. And we have things like this part of the small intestine, the duodenum, the pancreas, and some of the colon, the kidneys. You know, kidneys are positioned way in the back, and they're actually retroperitoneal, behind the peritoneum. So when you look inside the body and move the intestines around, you still won't see a kidney because they are protected with lots of fat around them, and they are behind the peritoneum. The parietal peritoneum is retroperitoneal. That's correct. Again, behind the parietal peritoneum is called retroperitoneal. Whew. Okay. We'll see both in lab. Good. Okay, that's good. Good break. Now we're going to start from the top and go from the oral cavity all the way through the digestive tract, through the large intestine. We're going to go to the stomach, and I'm going to stop the tape. Just give us a little break. Good. So oral cavity on the top. Don't do much of this. We don't dissect in the oral cavity in lab. It's not a popular place to dissect. A lot of times the teeth are not there. People at this age of the bodies that we get have had dentures, and so the teeth have been removed. But we'll see. Just talk a little bit about it. I like the slide. Look at the size of your tongue in the cross section here, sagittal cross section. Look at the size of this tongue. All you see is this top part, you know. But the tongue obviously has to be attached somewhere. So it's attached to the inner side of the mandible all around. And there's a hyoid bone down there too, a little bit of a hyoid bone. So, but there's lots of different parts within the tongue. So your tongue has what's called extrinsic muscle, extrinsic, attached to the bones, to the outside. And it has intrinsic bundles too. So there are bundles within the tongue, and it allows you to contract the tongue in different directions. Makes sense? So you can wave your tongue or curl your tongue and stick your tongue out. So you have intrinsic and extrinsic muscles within the tongue. Cool. Alrighty, moving on. Okay. Teeth, tongue. I don't do anything with the teeth in this class. I was just at the dentist, and he was numbering the teeth, and so I was curious again. How do they number those? So we have 16 teeth on top and 16 on the bottom, and they start in the back of the right side, and they go 1 through 16, 8 and 9's in the front. And so I had a fill-in today on the buccal surface of number 5. So buccal means facial, and there's a buccal muscle here, and so in the cheek. So buccal means outside surface. Lingual surface would be the innermost. Lingual means tongue. So the inner surface would be the lingual surface, or buccal is the outside. He called it buccal though, and he always called it the buccal surface. And I asked him again today, why are you saying buccal? And he said that's buccal. It stands for buccal, and I don't know how that switched over, but that's the outside surface of the teeth. So I thought that's cool. So now listen to your dentist and see what number they're working on, and whether it's the lingual surface or the buccal or buccal surface. All right. So we need our teeth, of course, to break apart food, of course, nuts and all kind of things. And we need the tongue to position that food so that it is between the teeth, so the teeth can do their mechanical digestion or mechanical breaking apart. Also, you have your muscles within the cheeks, and they're both squeezing to push the food substance so it lines up between the teeth so you can squeeze it. It's going to move around, of course, and then you need your tongue and your cheek muscles to reposition it, and then you're going to chew again. So we don't even think about all that, but the next time you're chewing, now start to think about and feel your muscles in your cheeks and your tongue moving food something around just so it can get between the teeth and you can do a good job. Good. Cool. Saliva glands. I'm talking here. I can feel saliva going in my mouth. That's a good thing to keep it moist. We have 3 sets of saliva glands, so 3 on each side. And we see some pretty big ones right in front of the ear is the parotid saliva gland. And its ductwork comes through the cheek and just drops saliva into the mouth on the inside of the cheek. Good. Then we have submandibular. The mandible is your jawbone, mandible. So submandibular is underneath your jawbone. And so if you ever go to get a nurse practitioner, or if you ever had a cold or sickness, they're going to touch you right there. Don't they touch there to see if these saliva glands have gotten infected from all this bacteria and viruses on the inside to infect. They're going to touch you here, they're going to touch you under there to see if these glands have gotten infected. They would like to touch the other ones, but they can't, and those are called the sublingual below the tongue, sublingual saliva glands, and their ductwork comes right up into the area right below the tongue. So it's good. How much do we produce a day? Do you see what it says? Your book says 1.5 liters a day. That's kind of a lot of saliva. If you're chewing gum doing that, you're going to produce twice that amount of saliva. It's mostly water, but there's enzymes in there, ions, buffers, and so things to start the chemical digestion, even within the mouth. So that's why it is important. You're supposed to chew quite a few times to get the mechanical breakdown as well as then the saliva to start the chemical digestion, breaking apart foods into smaller molecules. Good. All right. We're good there. Okay, one other slide. No, that's good. The pharynx we've already covered. We talked about that with the respiratory system, air coming in the nasal cavity and then going down the pharynx or the throat. So we see the nasopharynx is this upper area with the eustachian tube is shown here to the inner ear. And then the oral pharynx is whatever you can see when you open your mouth and look in the mirror. You'll see the oral pharynx in the back, real shiny pink area. And then below, what you can't see then would be the laryngopharynx, that area that's where food will go down the back tube, the esophagus. Air will come anteriorly and go down through the voice box and down the trachea. Okay. The pharynx is a muscle. It's a muscular tube, just like the rest of the digestive tract. So as soon as food gets back there, it'll trigger the swallowing reflex, and the muscle will go through a peristalsis wave of contraction in order to get the food and drive the food down into your stomach. Kind of funny, isn't it? Because it's going with gravity, so you'd think it would just fall down, but it doesn't. Every time you swallow, we have a wave of contraction through the pharynx and then down the esophagus in order to get the food, and even fluid too, down into the stomach. Good. 3 phases. Buccal is for the facial or for the mouth area, really. Phase. Pharyngeal phase, this is where it really gets triggered to start the peristalsis, and then the esophagus phase is continue of that peristalsis wave-like contraction to get that foods or drink even all the way down into the stomach. Let's see, this just reviews them all. Just read some of the highlights of each of the phases. You can do that on your own. And then we see after the wave-like contraction, it's going to push it through the diaphragm. I like the pictures, the schematic here. It is accurate that the stomach is the touch right up against the diaphragm. The heart sits right on the diaphragm too, right there. So that we have this, and it's going to go through the diaphragm, and once it goes through the diaphragm, it'll be in the stomach. So that's kind of neat. Doesn't really make a plop noise, but I thought that was cool. Sometimes, we'll see a slide later on about sometimes if you get pushed real hard with lifting or doing some really hard compression, that sometimes the stomach pushes back up through the diaphragm and you have a little bit of stomach up here. And it's called a hiatal hernia. And we'll see a better slide a little bit later. But it gives people problems because that hydrochloric acid that a stomach can produce, then that hydrochloric acid will sneak up this esophagus a little bit. And that's what burns, and that's what heartburn is. So heartburn, it's not really your heart, it's your esophagus, because the heart's sitting right here though, so it's real close to the heart, so people think it's their heart, but it's really the esophagus burning because of the hydrochloric acid from the stomach. Good. Okay. The esophagus is a flat tube. If your notes say hollow, kind of cross that out and put a flat tube. It's not open, it's a flattened tube. And you can see the external layer of muscle, that longitudinal oriented muscle. So it looks just like a sartorius muscle or a gracilis muscle, a real flat and strap-like muscle. So you'll see that right behind the trachea. And you'd swear it was a regular muscle to move the body. Well, here it's moving food down from the pharynx down into the stomach. Cool. And it does do it with that peristalsis movement. But I was surprised when the first time I saw it, I said, wow, it looks just like a sartorius because it's a flattened tube. Good. Here's endoscopy, or a little camera looking down and inside of it, and look how shiny it is because of mucus lining to keep it moist and fluid. Down into the stomach as well. Esophagus and stomach. Those look good. You don't want to see growths or any ulcers or bleeding parts, little sections there. That's what you don't want to see. If that hydrochloric acid gets taken apart the wall of the stomach or the esophagus, you're going to have an ulcer. Okay, let's do the stomach and then we'll take a little break. Okay. So the stomach, hey, look at the shape of the stomach. Doesn't that look just like a wine sack or a Boda bag? Have you ever heard of that? I wonder why. So in years past, that's how they would store water and wine and other things, would be take a stomach from an animal, and they would use that stomach as a storage pouch. So that's why they're shaped just like that. Good. The illustrator had to take a little liberty here and moved it down away from the diaphragm. But this part here is really pushed way up right underneath this big diaphragm muscle that goes over top of the stomach and over top of the liver here on the right side. So parts of the stomach, though, as we see it, the esophagus is coming in, but really this is right up there against the diaphragm. And this part right here is called the cardia, or I've seen it with a C on there too, cardiac or cardia section of the stomach, and it makes sense. It's right below the heart, just on the other side of the diaphragm from the heart. So that's just where the esophagus comes in. And there's a sphincter there, cardiac sphincter, meaning that circular muscle gets really thick and can squeeze and can shut, and so that food and fluids don't get back up through there. We know that happens sometimes when we have a burp or we push some gas up through. We know that sometimes that opens up and lets things up into the esophagus. Not good. Well, if you draw kind of a line, or the area that is of the stomach that is touching the diaphragm is called the fundus of the stomach. The fundus, this top part of the fundus, has slightly different epithelial cells. They're producing mucus to line the stomach to protect it from that hydrochloric acid. All right, most of the stomach is the body of the stomach. It then narrows as the pylorus region. Pylorus. The pylorus antrium. Antrium means like a doorway. Antrium. This is a closing or narrowing down, getting ready to exit the stomach. There's another sphincter there. So that would be the pyloric sphincter, and that's going to hold things in the stomach until the small intestine is ready for to do any more digestion absorption further. So the sphincter is noted on this slide. Good. What else? How about some curvatures? Remember, yeah, curvatures on top. So a lesser curvature is the upper right side, and there's a membrane there. That'll be that lesser omentum going to the liver. Lesser omentum on the lesser curvature. The greater omentum is attached to the greater curvature, so the lower left area of the stomach. That's all for those. Pretty simple. Mesenteries, greater and lesser omentum, just covered them. So we're good. Good. And the stomach is real smooth on the outside. that adventitious layer, outside connective tissue layer, is very smooth on the outside. But on the inside, our stomach is not smooth at all. It's very convoluted. See, this is a real picture of cadaver. It's very smooth on the outside. We see a little bit of lesser omentum here, but greater omentum is all this fatty tissue off the stomach. Has nothing to do with the stomach function. It's just attached to the stomach and goes down. So we know functions of the stomach is to store, right? Mechanical breakdown, we're still churning the stomach, we're still using saliva, and we're using acids from the stomach to do more chemical and mechanical breakdown, both. We can begin to absorb a couple things into our bloodstream in the stomach. Not very much, but we see water, aspirin, alcohol, just a few of the things, that there may be one or two more, but not much, can start the absorption process into the bloodstream. So that's why we talk about water. You want to drink water, and it can actually start being absorbed right through the stomach wall. Most of it's not absorbed there, but it can start to be absorbed. So certainly we want that water to get into the small intestine, which is designed with a larger surface area for absorption. Good. All righty. When we mix all this foods together, it's not food anymore. It's called a chyme. Chyme is just a mixture of all these secretions and food into chyme from then on. Good. When you look at the stomach wall, there's actually considered a third layer of muscle. So we have the circular layer, we have the longitudinal layer, but it's not a complete layer, but said that the stomach has a third layer of muscle. It's not that important. It's all there to squeeze, right, and to churn and to help the chemical digestion. Good. Now you can look on the inside, and when these muscles are contracted, has some muscle activity, we can see lots of bumps or ridges, and those are called rugae. So rugae are the ridges, and it's because of the muscles contracted some, so it's going to make the inside convoluted. And the next slide will show that a little better of why that's really good. But it does have folds of the mucosa. Remember, the mucosa is the innermost layer, and that's where the absorption takes place. Good. Oh, I like this slide. This is the last slide we'll do. One more slide after this. And but look how this, when we contract the muscle wall, it convolutes into these ridges, and then you have gullies in between. So, and then of course they're lined with epithelial cells. This is mucosa layer with epithelial cells lining them. And so on the top, but also down inside. So these gullies in between are called gastric for stomach, gastric pits, or gastric gland. Remember, back in epithelium, glands are just lots of epithelial cells. So you can have a gastric, what do we have up here? Gastric gland secretions. You could have said gastric pit, too, is all the way down in here. And there's different types of epithelium. All right, we see that there are mucus cells. Epithelial cells, their job is to release mucus. Mucus is going to go on the surface and just line all this epithelium so that any really hard chemicals won't eat away at any of these cells. So we need mucus cells. Good. The parietal cells, they're down inside these gastric pits or gastric glands, parietal cells down in here. And you can see that they're releasing different things. Where they're releasing actually hydrogen ions separate from chloride ions, but they're mixed together real quick and form hydrochloric acid. If you had your chemistries, you know how strong hydrochloric acid is. Can eat away at clothing and other things. So you got to be real careful with that. And so it's pretty strong acid in your stomach, and its job is to break apart food substances into smaller molecules to get ready for that absorption process. Good. Parietal cells also release this gastric intrinsic factor. Gastric intrinsic factor. And that's there to help with vitamin B absorption later on. So it's not going to do any absorption in the stomach, but later on in the small intestine it'll help with vitamin B absorptions. Gastric intrinsic factor. What do we have here? Common problems within the stomach is certainly acid reflux disease. All right? You probably don't have it at your age group, but when you get up over 30 and 40 and 50, you get a little more acid reflux disease, or GERD. GERD. You've ever heard of something? Your grandma, your aunt and uncle has GERD. It's gastroesophageal reflux disease. Easier to say GERD. But that's when you have too much of that hydrochloric acid. If you have too much, and it can be triggered by nerves, emotions, as well as certain foods, that you have too much hydrochloric acid, well, it's sitting around there, and then if you burp or if it goes up in the esophagus, it burns the esophagus because the esophagus doesn't have mucus cells. So it has epithelial lining, but it doesn't have mucus cells. So hydrochloric acid gets up there, and that's what causes heartburn so much. And it can cause ulcers, because if the hydrochloric acid does wear away at the end of epithelial cells, then that's going to expose the blood vessels. And that would be a bleeding ulcer if it goes all the way down and hits the capillaries. Okay, so what do we want to do? We're going to get rid of that acid. We can do it by neutralizing it. Let's just eat some Tums or some Rolaids. It's just calcium carbonate, chalk, really the same thing. Tastes like chalk. Some of the cheap ones do taste like chalk. And but that'll neutralize right away. Neutralize the acid right away. And you'll feel better within minutes. So it's a really good thing. About 3 a.m. sometimes I got to roll over and go, whoops, I need some Tums, and sit up a little bit so I don't have as much acid reflux disease. I don't get it very often, but some say if you get it like 3 or 4 times a week, then you need to look for a doctor to help you with that. There's something else you can do though too. If you shut down those parietal cells, then you won't have as much hydrochloric acid. So that's exactly what Zantac 75. I guess now they have Zantac 150. But their job, and it's fun to see the ad on TV, and they say it just goes right to the pumps, the acid-producing pumps of the stomach, and now you know those are parietal cells. And so it'll shut down those parietal cells, not completely, but it does slow them down a lot, so they're not producing as much hydrochloric acid. So that's usually a good thing. You don't want to shut them down all the way because you need hydrochloric acid to help with your chemical digestion in order to get ready for absorption. Because if you don't get things ready, it's just going to go right on through and not get absorbed. So you don't want that either. Okay. What else do we have? A few chief cells within the types of epithelium here, and they are releasing pepsinogen, which does convert in the small intestine to pepsin, and again, more enzymes to help do more absorption of proteins. Here's another big cell, enteroendocrine cells. Enteroendocrine cells, or G cells. What's the G stand for? I don't know what the G stands for right now. Enteroendocrine cells, G cells. Oh, gastrin. Sorry. Gastrin cells. All right, and these are releasing hormones, the hormone gastrin. And so that's not released into the stomach, but these are being released into the bloodstream. So all of our hormones are released into the bloodstream. They travel, and this is a kind of a messenger that says we got food in our stomach now, and we're going to need some help with the chemical digestion. So it goes to the liver and the pancreas and tells them to start releasing their digestive juices, I'll call them, bile out of the liver, and it actually is called pancreatic juice out of the pancreas, and that goes right into the small intestine to help with chemical digestion. We'll mention this again, but that's gastrin. That's what the G cells are. All right, there's a lot on that. You had to write a little bit more because I know all that wasn't in your notes, so I'm sure please write all that down. Good. Next, ulcers. We mentioned ulcers before. Ulcers, a peptic ulcer in the stomach is a sore or even a hole in the lining, and it's important you have to have a bacteria. There's a bacterium called Helicobacter pylori, and I know I didn't say that right, but it's usually H. pylori is the way they usually say it, and that has to be there to actually form ulcers. But everybody that has H. pylori doesn't get ulcers. So there's some other factors, and we know stress and emotions can help us to trigger some problems. And so, but you have to have the bacteria there to form it. But not everybody gets them. So there's more factors there. Interesting for ulcers. Now, you don't like ulcers because once you have an ulcer and then it's open sore, and then the hydrochloric acid is going to hurt it even more. And then certain foods you eat will hurt in those ulcers. And the ulcers are common in the stomach, but also in the small intestine. So we need enough mucus cells to line all this to protect our own stomach wall from itself, from that hydrochloric acid and bacteria. Well, here's a picture I kind of snagged out of a doctor's office once, and looking over here to see ulcers. Perforated ulcer means it is starting to bleed now. Ulcers, acute, just not so bad. But look over here, we see hiatal hernia. This is where, again, with a lot of compression, maybe lifting a deadlift or some weights, case of soda or something, that we're going to then squeeze so hard that we push the stomach up through the diaphragm. So here's a little bit of the stomach up here. It's not supposed to be up here, it's supposed to be down below. So once it's up there, then there's some hydrochloric acid being formed right here, and that makes it easier to get through that cardiac sphincter and up into the esophagus. So this is why the people have heartburn, a lot of heartburn in this situation. Good. All right, we'll talk about all this other on the next set of slides. Okay, good. And that's it. I'm going to take a break, and we'll do another set here in a few minutes. Thank you.